I'm very excited to present our speakers today for our topic, which is navigating the hospital to home. This is such an important one. Unfortunately, a hospital stay is almost an inevitable part of aging, and it can create a lot of issues, a lot of havoc. I've personally just experienced one with a family member, a 3-week hospital stay. And so I fed some of that feedback to our wonderful speakers today because it was a very stressful experience. And even knowing what I know, it's always impossible to do everything exactly the way that you know it should be done. And so I think this is a great topic, and I think the more that we talk about it and prepare ahead of time, the better off we'll be when it happens. But I also just say you might not ever do everything perfect, and that's just the way it goes sometimes, and that's okay. We can't always avoid everything, but we can think about it ahead of time and set ourselves up for success in the best way that we can. So we have two speakers with us today that are both wonderful friends of Senior Concerns. We have Ellen Henahan, who has an extensive career working as a nurse in the field of end-of-life care. She's worked for Buena Vista Hospice and most recently as a palliative care nurse for Los Robles Regional Medical Center. And she currently volunteers weekly in our adult daycare center. We also have Katie Wiltfong, who is a medical social worker with over 10 years of experience assisting retirees and agers of all types with their healthcare related needs. She is the co-founder of My Solo Aging Solutions and also the Director of Social Services for Buena Vista Hospice. So I will start by turning it over to Katie.
Thank you, Martha, and thank you everyone for joining us today. Like Martha said, my name's Katie, and in addition to having worked with Ellen at Buena Vista in hospice care, I also serve as a care manager and power of attorney for healthcare for my clients who are aging and don't have any friends or family that can step into those roles. So some of the experiences and examples I'll be giving today are tied into when I myself have been in the hospital with a client as their advocate, as their power of attorney, navigating the maze of a hospitalization all the way through discharge. And Ellen today will be kind of sharing her own experiences, not only as a nurse having worked on the other side in the hospital, but also through experiences with her mother-in-law. So I'll turn it over to Ellen.
Good afternoon. Thanks for joining us. This is a picture, sort of a caricature of my wonderful, sweet mother-in-law, Louise. Louise was just the kindest. She was truly a study in grace. And after my father-in-law passed away in Toledo, Ohio, Louise was very brave and jumped on a plane with us at the age of 92, and for the first time in her life left Toledo, Ohio, and came to live in Southern California. She had a wonderful experience living in one of the assisted livings here, thoroughly enjoyed it. She was struggling a bit with her mild to moderate dementia, but always happy, always in a good mood, and just enjoying her life. So we're going to refer to my journey, our journey with Louise over about 2.5 years that she lived here with us. So one of the things we often hear about is having to go to the emergency room, always kind of dreaded, but we can arrive at the emergency room either by ambulance or by private car. So the word has been out that if you go by ambulance, you'll get much faster treatment. Well, I'm here to tell you that that's not always true, that if you are assessed and found to be stable, you may be moved right through to the waiting room. You may be assessed. The cost of an ambulance can be quite high for that. Once you get to the registration area or the waiting area of the emergency room, you're going to be assessed by the triagers. You're going to be registered. They're going to be asking you all kinds of questions, whether it's for yourself and for your loved one. What are the medications? What is the issue that brings you here today? Who's your primary care physician? All of those things are going to be asked, and be prepared. They're going to be asked more than once. I want to encourage you to know that the emergency room really is not a substitute for a visit with your primary care physician. And it's not for things that can be handled in a more outpatient setting. So everyone complains about how long the wait times are. And it is what it is right now. We've had a big uptick in COVID. We've had flu. We've had all kinds of norovirus going around. So anyone I've spoken to has shared with me that they've had long waits in the ER.
So once you make it through the waiting room, which like Ellen shared can be hours and hours, depending on kind of the severity of the illness and the reason that brought you there, you're then transitioned into an ER room, or unfortunately, due to a lot of overflow, that can be the hallway. I was with a client about 2-3 weeks ago, and the hospital was just overloaded with a lot of cases of norovirus and influenza. And my client stayed on a gurney in the hallway for about 2, almost 3 days, just because there was no beds available. So unfortunately, once you get out of the waiting room, it doesn't mean that you're going to have a bed or a room in the ER. It really depends on the availability. One tidbit I want to share is if you are not with your loved one when they're sent to the ER, let's say an ambulance is called and you're arriving afterwards, the best tip I have getting to them is to go through security. A lot of folks go in and want to speak to that triage nurse that Ellen mentioned. And a lot of the times they're pretty overloaded with checking folks in, getting kind of coordinating everything, making sure that the physicians and everyone knows who's there so they can triage the highest needs. When you meet with a security guard and you use language like, I'm here for so-and-so, they have dementia, I'm here for so-and-so, they won't be able to answer any medical questions, I have their med list, some of those items that are really important, usually the security guard will assist with bringing you back pretty quickly. And so once you are back in the ER area, whether it's a room or a gurney, you're assigned a nurse who's pretty much with you throughout their shift. Usually that's 7 a.m. to 7 p.m. and 7 p.m. to 7 a.m. That nurse is going to be checking in, and the first person who's really going to take an extensive review of your medication list, what brought you in, medical history. They're going to start building your chart in their system. So they'll be asking for a lot of information, medical insurance. You're probably going to answer a lot of questions and you're going to answer them more than once. But the importance of that piece is this is what's really going to be accessible for all of the physicians and other medical staff to be able to view and see allergies and the reason you really came in. I find right when you're coming into the ER and right when you're kind of admitted into that area, that's when the highest need to support someone and advocate for someone is, because there's a lot of question. It's very, very busy. There's not a lot of quiet time, and that can lead to some agitation and increased confusion for your loved one, especially if they're in the ER for quite a few days. I would say the average wait time could be a day, 2-3 days at this point. So you kind of have to be prepared that that time might be a little bit more tiresome and there might need to be a little bit more presence. Having everything documented or having a folder that you can grab is really important. And we'll talk about some of that later on, knowing what to bring and how you can be best prepared, because a lot of times these ER visits are at 2 a.m. when our minds are not working at their best. There's a lot of diagnostics and testing that will be ordered. So you might have your loved one all of a sudden being taken out for a CT scan, now x-rays in, now they're drawing blood, now they're saying they need a urine sample. There's a lot of tests and a lot of movement that happens, and that's all so important at the beginning, which again can cause a little bit more confusion and a feeling of being overwhelmed. So being present to answer those questions and give direction is really important. Sometimes we hear that people are admitted under observation, And this is really so different for everyone and everybody's experience and everyone's insurance. But some insurances don't pay for the entire stay. They'll charge you 20% because you're not technically admitted. So if there's ever a choice or a discussion, it's something to look into and something to question, because there might be a reason why they're thinking, I don't know if we really need to admit you upstairs. But if they're going to be doing that and it's going to be insuring some cost, it's something to definitely consider.
So with Louise, her first trip to the emergency room came as a result of her being diagnosed with COVID. It was her first go around with COVID, and she unfortunately was not able then to participate with any of the group activities there at the assisted living. So she was alone in her apartment and fell. So sent to the emergency room. My husband and I were notified. We were able to meet her there. We knew she had a positive COVID diagnosis, so she was put in a room in isolation. She was terribly confused because of both being sick and now in a new environment. And just as Katie went through, she had every test in the book, all the CAT scans, x-rays. They wanted to know if she had been injured during that fall. Fortunately, after about 24 to 30 hours, we discovered she had no new fractures, no bleeds, no anything else. We had been able to stay with her most of the time, which is difficult but the staff can't gown and glove and mask up to go into a COVID room and sit with her and still provide care for their other patients. So fortunately, my husband and I were able to spend a lot of time with her, assist her with meals, get her fluids. And then when they said, well, I guess we'll admit her because of her COVID diagnosis and she's a bit weaker, my husband and I talked it over and we actually declined admission to the hospital. So we requested that the assisted living admit her back, and they did. But their stipulation was that we had to have 24-hour-a-day caregivers privately in her apartment with her. Fortunately, we were able to do that. So we moved Mom back to her familiar surroundings. We had a couple of wonderful caregivers who stayed with her basically for the next two and a half weeks to kind of get her stronger, encourage food and fluids, and all of that. And at the end of that illness, Mom hadn't fully recovered. And we did make the decision at that time to admit her to hospice in case there were any further incidents. So in the emergency room, you're going to meet all kinds of people. There's going to be an ER physician. He's going to be the gentleman or the lady that's going to see you, going to triage. They are going to be the ones that will connect you with any specialists and your primary care provider. A lot of people think their primary care provider will immediately come to the emergency room and be with them. And that's not true. They will wait at home or at their office until the ER physician updates them. We also may have residents in our local hospital, Los Robles. We do have residents of different levels, year 1, year 2, year 3. They're going to be very involved in gathering medical history, medication lists, all of that. Specialists that you may be referred to might be someone like an orthopedic surgeon, might be someone like a cardiologist who would come and see your loved one right there in the emergency room. The nurses generally work a 12-hour shift, 7 a.m. to 7 p.m. And many of the emergency rooms no longer have CNA, certified nursing assistants, to assist with just the basic care of the patients. So it can be a challenge, especially, as Katie says, for some of our patients that have dementia. A lot of the techs that you'll meet will be an X-ray technologist, a CAT scan, MRI, people whose job is only to transport you from one location to another. And then you're going to meet the folks from intake. So someone who wants to know everything about your insurance. They're going to take your demographics. They're going to ask you if you have any information on files, such as an advanced healthcare directive. Do you have a post form? You know, who is the next of kin? Who's the person we should be in touch with?
And to piggyback off of what Ellen just shared, these are some of the main documents that are really important to have and to have accessible, maybe in a folder, something you can grab if you or your loved one is hospitalized. The first one being an advanced healthcare directive. Now, a lot of folks complete these when they're maybe doing estate planning, building their trust, but this form does not require an attorney. There are forms that can be downloaded from the websites. There are forms that are available through Kaiser, the California Hospital Association, and they're basically asking you, in the event of an emergency, if you could not make decisions for yourself regards to your health care and your medical choices, who would you want to speak on your behalf? And that form can list alternates. So if you are unavailable, maybe you have another family member listed, and then the person who is designating you as a proxy would then sign the paperwork. It does need to be completed when someone is capable and of sound mind. But once it's there, then you have a document that is legally binding, and it shows people at the hospital that you are in charge of making those medical decisions. Most nurses, doctors, anyone you run into is usually very pleased to know if there's a point person, because the hospital can be very busy. It can be very fast paced. And if you have had these type of conversations with your loved one and are able to speak on their behalf, that really assists with getting things handled appropriately and quickly. It's also a good idea when this form is being completed to talk about what it means, not just assigning someone to be your power of attorney for healthcare, but talking about what you would want in the event that you were to have surgery, if you were to need a feeding tube, if your heart were to stop, how much support, how much diagnostics, how much kind of advanced life support would you be open to? And so this form really empowers the person that you've chosen to speak on your behalf. There's also a form which we call the POST, which is the Physician's Order for Life-Sustaining Treatment. It's a pink form, and it actually is not a legal form. It's a medical order that needs to be completed with your physician. Most people, when they're completing it, do it at their primary care office or maybe before a surgery, but it's really stating what your medical choices are. If you do not want resuscitation, that's the number one question. And if you want to have all coverage and support provided, you can have limited interventions, which might still mean IVs, might mean antibiotics. And then there's questions regarding feeding tubes. Would you want a trial? Would you want a feeding tube or not want a feeding tube? So the form really is a big discussion about what your goals of care are. It can be changed anytime. What you write and what you select is not set in stone. Some folks will say, I do not want resuscitation. If something is to happen to me, I would like to not have any type of CPR. I do not want intubation. And then I've met with folks who, before a surgery, have said, since I'm in the hospital, and this is the only time that likelihood of being resuscitated is high, and if there were to be an event in surgery, a medication, issue, a reaction that wasn't planned, I would want CPR initiated, but only in this setting. So these forms are really universal and are important to start having those discussions like the Advanced Healthcare Directive, especially if you are a do not resuscitate and would not want heroic measures completed. The other paperwork that I think is really important to have is your medication list and what I call a baseline form. So for a medication list, it's always a good idea to go into Word. You can even select online some templates, write in the medication names, the dosages, how often you take them, and just have a printout that you can bring to your doctor's office and also have on hand if there is an emergency. A lot of times the nurses love when you just hand that to them, because then they can go back to their desk and input everything. And then that will kind of speed up how quickly the medications from the pharmacy can be brought to you or your loved one, especially in the hospital. Having to read the medications or remember them can be pretty difficult at 2 a.m. The other thing that's important to have is really a cheat sheet to either hand to the doctor or nurse or just to refresh your memory. It might have you or your loved one's name, address, birth date. If there's an emergency contact and you want to make sure that that's inputted in their chart, that's important. Any medication allergies, the name of their primary care physician, and other physicians that might need to be contacted. You might list out medical insurance information. Sometimes I will have photocopies of the cards that I can just hand over to the intake person, especially at 2 a.m. when reading those numbers is not going to be easy for me. They can kind of just input that information themselves. You might also want to write in just some bullet points about medical history. You know, what have been the primary diagnoses, any past surgeries that are important, and just write it very simply so that a physician or a nurse can glance at it and get a good idea of what the background is. Another good idea is to really make sure that you're writing how that person's typical baseline is. A lot of times older adults are brought into the ER confused, might be a little disoriented, and that might not be their norm. But perhaps the very well-meaning nurse sees that someone's 82 and thinks, oh, they have a dementia diagnosis. If you can communicate, or you also have it written down that this is not the norm, then that might kind of help the nurses and the physicians understand that there's been a change in cognition. There might be an infection or dehydration or a medication that's causing this. And it might kind of help them understand that these type of things have been sudden so that the treatment might be a little quicker.
Can't stress what Katie just said enough as an RN. So Louise, unfortunately, was declining. As I said, we had admitted her to hospice, but she was still enjoying her day-to-day activities at the assisted living. And one day out for the walk, using her walker, doing everything safely, the staff was phenomenal. Louise fell and she was taken back to her apartment. I met her there with the hospice nurse, and we decided to send her to the emergency room because it appeared that Louise had broken her hip. And that was going to be difficult to manage in her apartment. To keep her comfortable, she was in a lot of pain. So we sent Louise back to the ER, which we had hoped to avoid. You know, my husband was involved. Obviously, he was her power of attorney. We met with everyone. We had a pulse form. We had a primary care physician. We just wanted to hear from the ER physician, from the trauma surgeon who met us first, and the trauma surgeon then referred us to the orthopedic physician. We talked about all the assessments that they had done. Louise's heart rate was quite erratic. She had atrial fib, which we had sort of known about, but we had chosen not to treat aggressively because the burdens of that treatment could have outweighed the benefits for her. So after a long discussion between my husband and his brother, and just hoping that Louise, knowing she would most likely not return to her previous baseline, but getting her out of pain and comfort, we elected to have her go to surgery and do the hip surgery. The surgeon was very reassuring. He promised us he could bring her through it, you know, comfortably and safely. And so she was in the ER for about 20 some hours until she went straight from the emergency room to the operating room. From the operating room, she was sent to the orthopedic unit where we were waiting. And again, so all new nurses up on the orthopedic unit, and we had to review all the medications, the baseline, what her needs were, what she would need help with. And they did a great job. You know, Louise was out of pain when she came from the operating suite.
And so when you are in the ER, usually once it's confirmed that you're going to be admitted or your loved one will be admitted, you're chomping at the bit for when you're going to get to go upstairs. That's usually the language that most nurses and doctors, especially if you've been down there for a few days, are telling you, soon we'll get you upstairs. I always laugh because I think it's Murphy's Law, but the second you leave, that's when that person's going to be sent upstairs. It is what it is. But I will say, as someone who tries to be present and there, when to prevent any fear or concern, I always have found that the transport is always smooth. My clients have always shared a laugh or been just very comfortable with the folks that transport them upstairs. So most hospitals really do a great job at making sure those folks ensue that really smooth transition from the ER up to the floor, whether that be telemetry, whether that be med surge, whether that be orthopedic and oncology floor. But that transition upstairs can happen at any time when that bed is available. A lot of the times folks feel like, oh my gosh, there's empty rooms. Why aren't we just being able to use them? And that's due to staffing. You really want to make sure that the nurse assigned to you isn't assigned to far too many people that they can manage. So hospitals keep a pretty strict staffing ratio, which is important because when your loved one hits their buzzer or you're there and have questions, you want that person accessible and available. Once you get upstairs, like Ellen mentioned, to whatever room, you're meeting with a new nurse. And that nurse on some of the floors might be there for a few days and have the same patients, so that can be helpful. But oftentimes with each new nurse and each new shift, you're really starting over, sharing the story, and especially the things that might matter most to you for your loved one. So not only their medical history and what brought them into the hospital, but you might also share that they have some anxiety. You might share that they're not great sleepers. And that's something you want to make sure. They've always had a sleeping medication. You want to make sure that's given to them. All those conversations, I have always found the nurses soak them up because they want to make sure that they're providing the best care, and they want to know the little things that they don't have to discover later on. The more information, the better. When you or your loved ones in the hospital and you're moved into a room, it is night and day from the ER in terms of quiet. You have privacy. There's a bathroom. There's a TV that you can actually hear because there's not people, shuffling by. A lot of the times your loved one might sleep a little bit more, and that might not be a reaction to medication or the reason that brought them in. It really might be because they didn't get good restful sleep. I always find that when someone finally gets that good sleep, you kind of see them get back to baseline a little bit. They might have been a little bit more anxious and confused in the ER. And once they have that restorative sleep and that quiet time, you start to see them acting more like themselves. Having comfortable clothing, sweaters, blankets, things that are easy to take off. You might not need to be wearing pants if toileting's an issue, if someone's wearing briefs or is using a bedside commode, but they might be more comfortable in a t-shirt versus the big hospital gowns. A cozy blanket's always nice too, that makes someone feel like home. And usually reading materials, word search, things to keep people's minds off of sitting in bed can really brighten moods, I find. Cell phones, dentures, hearing aids, these are all things that can be brought to the hospital for comfort and to normalize the experience, but should also kind of be monitored depending on your loved one. I have clients whose hearing aids, I would pick them back up at night because they were the type that would fold them into a little tiny napkin and stick them on the dinner tray, or, take out their teeth and keep them in bed. And you can't blame these sweet folks at the hospital who are coming in to change linens and gather trays. I'm sure they're trained to look, but things can so easily be misplaced. So I always gauge what I bring based on how the person's feeling and what's most appropriate. If the hearing aids aren't really needed because they're going to sleep at night, you might take them home, or you might put them in the cabinet and let the nurse know that you've taken them out for right now, but please put them in for that comfort and that so they don't feel as vulnerable. So again, these are good conversations to have when you're meeting with the floor nurse. You do not need to have any cash. We no longer have the candy stripers who are selling magazines and cigarettes. So there's really no need to bring any cash. And any valuables, jewelry, anything of that sort you really don't need in the hospital. Medications cannot be given unless they're coming through the pharmacy. The only time that would be helpful is perhaps if you don't know the dosage or you're having trouble reading the bottle, it might be helpful to bring in and show, but that can't be left in the room.
So who are all these people that you get to meet in the hospital? So often in most rooms, we will have a whiteboard, which can be kind of old school. It's got the black marker and you just write on it. The nurse of the day might write on it. Or we may have the more updated electronic one that will have the hospitalist, the physician that's seeing your loved one, the name of the nurse, the name of the charge nurse, and maybe the name of the nurse's aide or CNA who's caring for them today. A hospitalist is kind of a fairly new term in the last probably 5 to 10 years. Hospitalists are physicians that work only in the hospital. They do not have a private practice outside. They will communicate with your PCP, and the PCPs, as we said before, don't typically visit the emergency rooms. Again, with hospitalists, we are also at a teaching hospital, so you may have residents and you may have interns. And I think that's kind of old terminology. It's levels 1, 2, 3, or post-grad 1, 2, 3. I'm really dating myself when I say interns and residents. Our charge nurse for the floor is someone that's going to kind of oversee the entire unit, all of her staff, any issues. She's going to be the person you would go to if there was really a concern that your nurse couldn't handle. The assigned nurse is going to be responsible for the direct patient care, any medications, treatments. They're going to be the ones notifying the hospitalist if there's any change in condition. They might be notifying the specialists and trying to help just make sure everybody's sharing the same information. A certified nursing assistant, again, is a CNA. They might assist with taking the patient's vitals, helping them use the bathroom, changing linens, helping set up and maybe feed them meals, or at least getting meals cut up and prepped, and helping them ambulate, moving them from the bed to a chair if that's okay, or maybe even taking a little walk if that's advisable. A social worker is not usually assigned to each unit, but there's several social workers in the hospital, and they're going to help patients that have more complex issues, psychological needs, family disputes. They're going to help identify the decision maker if you haven't brought your advance directive, and if there's differing opinions on what should be done. The social worker may coordinate with APS or the police, and APS again would be Adult Protective Services. If any professional there at the hospital is concerned about the condition of the patient, concerned with neglect or possible injury, they may reach out to APS or the police. And then the most important person, Katie?
One of the most important people you'll speak with in the hospital is the case manager. And this is the person who's really helping you coordinate care and helping to come up with a safe plan for discharge. So case managers are nurses by trade primarily, and they work with the assigned nurse and the physicians to come up with the plan of care and assist with some of the practical coordination. So they might be assisting with coordinating the outside services and looking into what the doctor is going to be ordering once someone is discharged. That might be going to a skilled nursing facility, which we'll talk about in a few slides. And that might be going home with home health or hospice care. That might be identifying that someone is not safe to go home and live on their own as they have. So they might be discussing with the patient or the family caregiver referrals. It's really a point person to help look at, here is all the care that's being provided in the hospital. And we know that once you go home, unfortunately, most people don't snap right back to their baseline. There needs to be a plan in place. There needs to be follow-up care. Some folks might now need dialysis. A case manager could be the person who's saying, the doctor's referring you to this dialysis treatment center. There are options for transportation, and really coming in and taking an inventory of what the needs are going to be from each person to make sure that when that order is written for discharge, that there's not surprises and that there's a plan in place that everyone feels comfortable with. The case managers, unlike the nurses assigned, are usually covering a lot of patients. So you might not speak to them daily. They usually sit in an office on the floor, and then they do their rounds and go room to room, and also spend a lot of the time on the phone with the physicians and also setting up a lot of different care options. So you might not hear from them as often, but that doesn't mean they're not working behind the scenes. It's also important to speak up and advocate because they are managing a lot of patients. So it's okay to get their contact information. It's okay to knock, knock, knock on their door if you're visiting your loved one, and just try to get updates in real time and let them know that you're available and that you want to make sure that you are chatted about and in the loop for any decisions that are made.
So my wonderful Louise was admitted to the orthopedic unit after her hip surgery, which was successful. She was awake. Pain was an issue for a bit there, and we tried one of the milder pain medications. Unfortunately, she had an adverse reaction. So again, I happened to be there. I was able to alert the nurses, have people come in and witness it. So we were going to hold medication, and my 91-pound mother-in-law, she was well managed from there on out with extra strength Tylenol and did very, very well for that. Louise was not eating or drinking well, and we really wanted to encourage that. So we were able to hire again a private caregiver to sit with her for the times that my husband and I weren't able to be with her. It was very reassuring to her to not be in the room alone, and very helpful to encourage her to kind of move around, take deep breaths. At that time, Louise was evaluated by the physical therapy team in the hospital. So you would have to do that after having had hip surgery to kind of understand what the plan was for rehab. So Louise, because of her dementia, because of the surgery, because of so many things, she was really not able to participate at all in physical therapy. So that's a new data point for my husband and I to think about as we made our future decisions.
I want to specifically talk a little bit about managing dementia in the hospital, because these are folks who really are going to need a little bit more support and oversight if your loved one isn't able to speak for themselves or to be a reliable custodian of their care. It's really important to be prepared. Have all of those documents we spoke about earlier, have things written down, and know that you will be their voice. A lot of folks can feel a little scared, and so having that person there who's reassuring, who's answering all their questions. I know when I have clients who do have memory deficits and the doctors walk in, they've got a to-do list and they're asking a million questions, and they'll just point at me, and it's reassuring that there's someone there who can speak up, especially when they're not feeling their best. You will need to over communicate. Each person walking in might not have had a time to check out the client portal, see the updates in the chart. So you might need to, again, say the same things over and over again, but know that that person now understands your loved one's abilities, and they understand that there might be some deficits and there might be some ways that they can change how they approach your loved one. So over communicating concerns and ways to speak to your loved one if they're fearful or confused is so important. Being present is another one. Ellen spoke a little bit about being able to hire someone to sit by bedside. And if that is feasible, that can be a big help. This is the time to really call on your phone tree. because as someone with dementia, there's not the staffing typically at the hospital to have what we used to call a sitter, where someone sits by bedside and ensures that someone stays in bed, is safe, is comfortable. Nowadays, unfortunately, there's just not that staffing. So it does fall to the family to be there, especially if someone's a big fall risk. The beds will have alarms that will sound, but you don't want it to get to that point where someone's on the floor for the nurses to find if there's other people who can kind of rotate being there. And your loved one might get more oriented once they get to a room, and getting up out of the bed might not be as big of an issue, because once they start moving and the alarm goes off, the staff will hear them. But at the beginning, it might be helpful to have someone there more often, and having a calendar or folks who can rotate shifts, even if your loved one's sleeping, that peace of mind knowing that you can go home and rest and take a shower and someone's there is completely worth it. Advocating is another big piece of being with someone with dementia in the hospital. You might notice that there's change in behavior that the nurse might not know, because she doesn't know your loved one that well. They might have pain, and that might be expressed through a lot of agitation, a lot of restlessness. So communicating those cues that you're picking up on can be very helpful with them getting the best care. A lot of the times folks in the hospital do get what's called sundowners or hospital-induced psychosis, and this can happen with people without dementia too. You can get increasingly confused and disoriented and not behave like yourself. And that sometimes can happen, but it's also important to know if there's maybe a reaction to medications. A lot of older folks are thought to be, oh, they're just having that, that moment, they're fine, they're just confused. But I've found that sometimes having a video of a client a few days prior and then being able to show the nurse how much the change has happened from their baseline has helped them figure out that there was a medication interaction, not them just being confused in the hospital. So having an advocate by bedside is so important for folks who can't speak for themselves. And in addition to bringing a cozy blanket, I have found that those little CD players you can get on Amazon are a godsend. You don't have to worry about something happening to them, like a big expensive iPad, but you can hook them up and just play some jazz music or your loved one's favorite music, and that can be so calming and really help in these moments where they're having some more agitation or confusion.
So as I alluded to, we had to have some important conversations. Louise's baseline really had changed. She was not able to participate in any physical therapy. She had had a pulse that had been sort of, we had designated a DNR, and she had actually signed that. That was her request. The DNR had actually been suspended during surgery, which is not at all unusual, because the surgeons want, in case, as Katie alluded to, a reaction to a medicine, something unexpected happening. They want to be able to treat it and bring that patient successfully through surgery. But once Louise had been out of surgery and up on the orthopedic floor for a couple days, we were able to meet with the hospitalist, get the code status clarified. We wanted her DNR status reinstated. And then we needed to talk about the new goals of care. How would Louise do? Most patients who have hip surgery are eligible to go to a skilled nursing facility for physical therapy and rehab. Was that a realistic goal for Louise or not? And then, if it wasn't, if we thought it would be more burdensome to her than benefit, then what should our next step be? So again, including the rest of the family. And we visited several of the skilled facilities that Louise was eligible to go to, and we talked with all of the family. And again, we decided to take Louise back to her familiar apartment, and we were able to, again, to bring in some private care, because for her, that was the best. She sadly really never regained her ability to get up and stand and walk again. And she really even wasn't able to ride comfortably, which had been our hope. that she could at least ride it comfortably in a wheelchair and still participate in all the daily activities that she so enjoyed at the assisted living. But that wasn't to be. That wasn't to be.
When you finally get that discharge order, usually it takes a physician, well, I would say it usually takes a few days of thinking you'll be discharged or your loved one will be discharged. And then finally the physician coming in and saying, I think everything is stable enough. I think we're comfortable with you leaving the hospital. The physician will then write an order and you will be in contact with the nurse and the case manager for the follow-up instructions and the plan moving forward. If you, for instance, need durable medical equipment, so there's been a change with your baseline, you now require maybe a hospital bed, perhaps oxygen would be helpful to go home with. All of those orders will be coordinated from the hospital so that the equipment can be delivered before you go home. The case manager can also assist with setting up transportation if you're not able to go by car. Usually that's non-medical transport, which is not covered by insurance. A lot of the times the case manager will give a loved one or yourself a phone number and say, call them and pay by credit card. But they're usually wonderful folks who are able to bring your loved one or yourself home by wheelchair or gurney. If you require an actual ambulance, then that might be covered by insurance, but that would be if you're moving to a higher level of care or an equal level of care, whether that be a respiratory hospital, whether you're moving to a subacute floor at a different hospital. Usually that is for much higher needs patients who require that life support transport. You'll be given a new list of medications that will have any new prescriptions added. And then the hospitals nowadays don't typically send you with a script. They will fax your new medication order to your pharmacy. I have had it on the weekend where they've handed me the script because the pharmacy that was not local that provided medications by mail wasn't open. So you can request either one, but it's a pretty seamless process. They will also give you a set of discharge instructions with information. And usually there's an encouragement to contact your primary care physician or a specialist, cardiologist, pulmonologist, and schedule a follow-up appointment as soon as possible. Most doctors do set availability up for these type of follow-up appointments. Lastly, the appeal process is usually questioned. And before Ellen and I came up with our full agenda for today, we both spoke to case managers, making sure that we had all the accurate information. And when I spoke to one recently and asked about the appeal process, she said, based in her 30 plus years, she could count how many times someone has won the appeal on one hand. So it doesn't mean it's not worth a try, but it's usually based on your insurance and whether or not they feel the person still needs to be hospitalized or they feel they can resume care in another setting once discharged.
So although we elected not to take Louise to skilled for rehab, we were given a list of the local skilled facilities that Louise's insurance was accepted by. Now, interestingly, her insurance that was fabulous in Toledo, Ohio, wasn't as well regarded here in Southern California. But we still had a list of several facilities that accepted her insurance, had a bed for a female, and were ready to accept her. So my husband and I were able to tour those. They skills facilities sometimes aren't local if they don't have a contract with your specific insurance. So often I've spoken to families who say, oh my gosh, they want to send me to Torrance. They want to send me out to Ventura. Well, those are the only facilities that actually have an agreement with your insurance company. So you can request that list of skilled facilities that would be a possibility for your loved one, set up the tours, which we did. Something that's important to remember is sometimes the most aesthetically pleasing, the most beautifully decorated skilled facility is not always the best. Sometimes those ones that have a little bit more scuff marks, they've been around longer, their staff has worked together, and they really know their skill set. Medicare Advantage plans do not always have a lot of contracts with local skilled facilities. And you cannot ask the case manager or just refuse to be discharged from the hospital until a bed opens up at your skilled facility of choice. So that doesn't work. You don't get to just stay until the room becomes available. How long would you stay at a skilled facility? It's really determined by your insurance and by your ability to participate fully in the rehab. Non-compliance, someone who just refuses to get up and they're not making any progress, then the case manager or the social worker, someone at the skilled facility is going to be reaching out and saying, Medicare won't allow us to continue providing care for your loved one. So if they say, oh, well, we'll pay privately, just be aware of what you're signing up for, because the daily rate at a skilled facility can be quite high, even if the facility has a bed that they could allow your loved one to stay in. If you are on Medi-Cal, that's the only time you see that someone has custodial care in a skilled facility. Some patients who are both maybe Medicare and Medi-Cal, and Medi-Cal is the California version of the insurance for those who are quite destitute, quite poor, they can live for a long time at a skilled facility. And again, then as Katie said, non-medical transport to a SNF is not covered by insurance. And so now it was time to talk about, because the case manager was meeting with us and telling us that Louise was not participating in physical therapy at the hospital. Were we going to try a skilled facility? What did we want? So our decision was that we would take Louise back to her apartment. We would readmit her to hospice because she had come off of hospice care once we brought her to the emergency room. And we were able to supplement her care at the assisted living with more private duty. The case manager helped me get all the DME, so the durable medical equipment, delivered to Louise's apartment. We had an overbed table, we had a hospital bed, I had an air pressure mattress, I had a small transport wheelchair. All those things were there and ready. Our case manager set us up with the medical transport that was able to move Louise by gurney comfortably back into her own apartment. And actually, it went just seamlessly. We had a very, very good experience. And we were able to use some of the same private caregivers that we had used both in the hospital and during Louise's previous experience with COVID.
For most of us, our goal is to not go to a skilled nursing facility. It would be to go home. And being prepared at home is so important because you want to make sure that you're not going to go back to the hospital or your loved one's not going to be rehospitalized. The ways of going around this is having extra support and being prepared. That might mean bringing in hired caregivers. While the cost of caregiving can be high, it can be so helpful to have that available support for the first few days or first week. That ensures that you are going to be able to get some sleep, that someone will be tending to your loved one, and making sure that their adjustment back home, their adjustment at their new baseline, they'll have that extra layer of support and oversight. There's a lot of support that can be provided through local resources like meal delivery, Meals on Wheels through Senior Concerns. There's great support groups if you're now navigating the role of the caregiver. There are adult day programs. If once your loved one is capable of leaving the home and are feeling a little bit better, they might need that daily oversight because being home alone might not be feasible anymore. And it's so important to take care of yourself as the caregiver and make sure that you are being realistic, that how your life was before might look a little different. It might not be permanent. There might be just some additional support and needs, or you might be looking at reframing how best you can care for your loved one and knowing that it's time to bring in a little extra support. That might mean through home health care, which can bring out nursing visits, physical therapy, occupational therapy to continue the support that was provided in the hospital. Or as Ellen has shared, it might be time to move towards hospice, where you're looking to keep someone out of the hospital and really have that comfort focused care at home. If you are the caregiver and you are worried about being hospitalized, this is definitely the time to make sure that you have those plans in place. Have that phone tree, have those available family and friends who have asked for years how they can help. Say, in the event something happens to me, I need you to go to my house. I need you to get my jammies. I need you to call this person, and kind of come up with a plan so that you feel a little bit more comfortable. Martha and Senior Concerns are gracious enough to share these books that they have made. It is The Hospital to Home. When I realize my my background's not helpful, but they're wonderful books that kind of go through different information that you might find. They have room to write notes. They have room to have hospital guidance, oversight of the different folks you might meet, medication lists, and there are available in Spanish as well. So if this would be helpful to you guys, they are available at Senior Concerns. And we'll turn it over to you now, Martha, if anyone has any questions. But thank you guys all for tuning into us today.
Thank you so much. Oh my goodness. And you went exactly up till 4 o'clock. If you don't mind unsharing the screen, Katie, so they can just see us a little better. Thank you. That was chock full of so much information. And it's funny because there were so many pieces that I would think to myself, ooh, about things I want to add in because things I've heard or just having been through this experience myself. I mean, because I think every hospital stay is different. And that is what makes it, I think, a little bit challenging because one time you might have a good system and you think, okay, I'm understanding this. And then the next time things go a little bit different because maybe the hospital's busier like it is right now. And so they don't have as many things available. But I will say that whiteboard in the room, they now will give you a direct cell phone number for the nurse for the day. So that's excellent. The second we would go in the room, we would take a photo and text it to our family so that we all had it. It changes every day. My father-in-law was able to get a sitter from the hospital to be with him, but only on day 6 after 5 very stressful days of his behaviors really exacerbating from being in such an uncomfortable situation with dementia. And so I wish that I had hired somebody sooner. And I offered, and I had discussed that with the nurse, with the doctor, and they said, oh no, we're putting that order in for the sitter. So don't worry, we're going to do that for you. And it wasn't until day 6. So you really sometimes just can't wait. I know it's 4 o'clock, but we have a couple of really great questions. So if people don't mind, we'll just go a couple minutes so we can ask some of these because I think they are very specific and helpful. One is the ambulance service covered by insurance? And do you get to choose what hospital do you go to? I think I know the answers, but I'll let you answer.
So you generally don't get to choose what hospital. And I'm not an expert in that. What I've been told is that the ambulance is covered if it's truly ambulance level necessary. I mean, you're still going to end up paying part of it, whatever your deductible is and that, this and that. But I've heard people say that, just call an ambulance and you'll go right into the ER. That doesn't work anymore. So, and understand, I don't know how your insurance works, but you may end up with quite a bill for that.
You really might, but I will never forget a talk I heard once from a man who decided to drive himself to the hospital and then had a massive heart attack in the car. And so if you feel it's medically necessary, you will deal with the bill later. Come to us, we will help you talk about options.
Yes, please.
But yes, there is no guarantee because it does depend on your insurance. And we all know that none of us have a magic ball to understanding insurance.
No.
I wish we did. You talked about all of the documents to have, insurance cards, healthcare directives. Is a photo on your phone acceptable?
Yes, I think that's definitely feasible. I haven't found that they want their own copy. Usually they just want to be able to type that easily into their system. So if you don't have it available to hand to them, you can obviously pull it up on your screen and zoom in, and the intake gal, I'm sure, will be very happy with that.
That's one thing I had my father-in-law's insurance cards on my phone, photos of them. And I was very, very pleased with myself for having that because it did make it easier because I was able to give all the information in the ER. Is there an association of folks like Katie who act as POA for solo agers in other areas? This person is in San Jose.
Okay. I don't know for sure the San Jose area, but there is an organization, Aging Life Care Association. They've changed their names from geriatric care managers, but they're easily found on a quick Google search. Not everybody serves as power of attorney for healthcare, but they might be able to give you some support or at least be a good advocate in the hospital. I, for instance, have clients who have family that are their power of attorney for healthcare, but I'm more or less the local feet on the ground if something is to happen. So there might be people part of that organization that could do the same.
Thank you for that. I think what your organization provides here is very unique. But yes, I think looking at aging life care or geriatric care managers, they would probably be the best to give you that referral. How to get discharged when no one is helping you and it is in your best interest to leave ASAP. And I'll let you speak to the medical part, but I will just share that with the recent situation with my father-in-law, we were unable to get him into a skilled nursing facility, which was our plan for discharge. And it sort of came to a moment where it felt like it just wasn't going to happen. And in the meantime, he was just getting worse and worse in the hospital without being able to walk and move around and with his dementia. And so we made a plan for taking him out, but making sure that he had care in another location that we had to pay for, privately. And we just declared to them that that's what we were doing. And the doctor was fine with it and wrote the discharge papers. But the discharge planner didn't know, the case manager, because we communicated directly with the doctor. So I do wish that I had closed that loop because in the meantime, she was still behind the scenes. Little did I know, because she was not communicating to me, trying to find a bed for my father-in-law. So it gets a little bit complicated. But Ellen, do you want to share? How does that work with the hospital?
I would agree. When Louise had COVID and putting her in a private room upstairs and again isolated away from everyone wasn't going to be in her best interest. Her primary care physician, I was able to reach. He was able to reach out to the hospitalist. I was able to reach out to the case manager. And again, it's only because I know that whole system and the nurse. And the nurse in the emergency room was quite delighted because I knew that I had to reach out to the assisted living, make sure they would accept her. I knew all those steps. So is it easy? It's not. So how do you get someone out ASAP? I would take your time, ask all the questions, because again, leaving AMA against medical orders, you could really incur quite a bill.
Thank you for that. One last question to clarify, because someone's asking that they thought hospice was when you are about to die and you would not have hospitalization available anymore. And I know you explained to Ellen. How did you
So
do that?
hospice is when you would not be surprised that someone would pass away in the next 6 months. And after Louise had COVID, we were definitely expecting her to just continue to decline and pass. And really part of that decline was that she fell and broke her hip. So you always have the right when you're on hospice to revoke, to stop hospice care. and elect more aggressive treatment, like going to the hospital for pain management. And that's really what we thought we were doing. We really didn't expect to do surgery. But after meeting with all the multiple specialists, they explained to us that that was the best option to get her pain-free. And again, our goal was just to let her ride in a wheelchair and enjoy her life for daily activities. So hospice is not for the final few days of life. President Jimmy Carter just died after, I think, 1.5 years with his advancing melanoma. So as long as the patient continues to decline and has a terminal diagnosis, and it is a bit more complicated than that, they are eligible for hospice care.
Wonderful. Thank you so much. Well, I know we've already gone over our time, but I want to thank you, Ellen and Katie, so much for all of this really excellent information. And just to say to the audience, thank you for tuning in. I will send around the recording, but also if you find you or your loved one in this situation, you can always call Senior Concerns and we can help talk it through with you, because sometimes it is just really helpful to talk it through with someone else when you're in the middle of what really feels like a crisis. So thank you to everybody for joining us today, and I hope you all have a good evening.
Great. Bye, everybody.